We are Group 9 and we will be discussing smartphone applications in ophthalmology. Catalina will be presenting Component A, Josh will be presenting Component B, and Cami will be presenting Component C. Thank you for listening.
Hi everyone, my name is Catalina Yurchima and I'm going to be covering Component A, the Intro into Ophthalmology. Before we start looking at smartphone applications within ophthalmology, it's important to take a look and understand why vision impairment, vision loss, has become a public health concern within the United States. Overall, ophthalmology-related health concerns is currently a growing issue. According to the data published by the Center for Disease Control and Prevention, there are over 3.4 million Americans with a visual impairment or are blind and are also over the age of 40. It is estimated that a total of 80 million Americans have eye diseases that can lead to blindness. In addition to the large numbers of affected people, the other issue to consider is that there are many people who also suffer from multiple health concerns. For example, a person diagnosed with severe vision impairment is most likely to have diabetes, arthritis, and mobility issues. As the population continues to age, the rate of vision loss and vision impairment will also continue to increase. On this slide, you can see the prevalence of visual acuity across the United States on the left-hand side, and on the right-hand side is the prevalence of vision impairment within New York State. So when we're looking at the map of the United States, you can see that West Virginia, Florida, and Arizona tend to have higher rates in comparison to states such as New York or California. You can see that the colors for these states are darker. And then when you take a look at the map for New York State, the highest prevalence for vision impairment is around the northern and rural regions. So you can see that the deepest blue is closer to the Buffalo state line. Whereas if you take a look at the tri-state area, that is where you have the least prevalence. When looking at the overall prevalence of visual disability across both female and males, ages 16 to 75, across all races, regardless of ethnicity, and all education levels within the United States, you can see that the total is 7.6 million, or 2.4% of the population. In women, the prevalence is 3.9 million, or 3% of the population, which is higher in comparison to the total for men, which is 3.2 million, or 2.65%. Ages 16 to 64, it's a total of 4 million, and ages 65 and older, it's 3.1 million, or 6.6%. So you can see that the highest prevalence is among adults ages 65 and over, and also among women. This slide provides a general overview of the most common eye disorders and diseases. One that jumps out the most is diabetic retinopathy, as it is a disorder that is brought on because a person has developed diabetes. This disorder can be prevented in several levels, including by improving a person's nutritional and lifestyle choices, and also by having regular annual eye exam checkups. This is also the one that is most commonly known. Diabetes is the leading cause of blindness in adults within the United States. About 42 million adults have been diagnosed with diabetic retinopathy. This eye disease occurs when high blood sugar levels cause damage to the blood vessels in the retina. There are two forms of diabetic retinopathy. The first one is non-proliferative diabetic retinopathy, also known as NPDR. NPDR occurs when tiny blood vessels leak, which makes the retina swell and can eventually lead to vision loss. The more severe vision-threatening form is proliferative diabetic retinopathy, or PDR. Here, the retina starts growing new blood vessels, which leads to floaters that can eventually block a person's vision. Additionally, scar tissue can also grow and will lead to a detached retina. Diabetes-related blindness has led to about $500 million in expenses, all of which can be prevented by early detection, constant monitoring, and maintaining good control of blood sugar levels.
Hello everyone, my name is Joshua Thomas Gallo and I will be discussing the limitations of traditional non-technology based approaches in ophthalmology. Upon initial research, analysis of the current approaches in this field indicates the ubiquitous use of technology. There are very few non-technology based approaches, and the reason for that is the need to evaluate the eye for any issues requires technology based tools. Effective visualization of the eye and subsequent eye surgery, if indicated, cannot be completed without technical tools. Thus, I will delve into some history of ophthalmology and some non-technology based approaches and common features in this field. Thank you. The history of ophthalmology is fascinating. Some of the earliest findings of eye surgery can be traced back to ancient Babylon in the Code of Hammurabi around 1800 BC. In ancient Egypt, eye care and treatment were first mentioned around 1500 BC on papyrus. Trachoma, a disease caused by the chlamydia bacterium that could cause blindness and blurriness, were both treated with ointments. In ancient Greece, many notable philosophers and physicians discussed ophthalmology. Alcmaeon, Aristotle, Rufus, Galen, Hippocrates, and Herophilus were some of the first to examine the eye, conduct cataract surgery, and create detailed descriptions regarding anatomy. Ancient Indian surgeon Sushruta was one of the first to define multiple diseases and expanded the use of couching to treat cataracts. He is also known as one of the first fathers of surgery. In ancient Rome, Celsus was a pioneer in the field around 2,000 years ago. In the medieval Arabic period, Hunayn ibn Ishaq was one of the first to write a textbook regarding treatments of the eye around the 8th century AD. The Renaissance period featured a great advancement in the field with work by notable scientists such as Berengario, Vesalius, Maitre Jean, Malpighi, Leeuwenhoek, Reich, Petit, Eves, Daviel, Bartisch, and Zinn. Utilizing a microscope allowed for better visualization. Beer reevaluated cataract surgery. Von Graeff and von Helmholtz invented the tonometer to treat glaucoma and the ophthalmoscope, respectively. Goldstrand invented the slit lamp in 1911, which ophthalmologists still use today. Meyer Schwickerath treated retinal defects in 1946 with laser photocoagulation, which was the first time lasers were used in medicine. Ridley and Kellman have contributed to a revolution in cataract surgery, allowing it to be performed in an outpatient setting. I will now discuss the basic makeup of a traditional comprehensive eye examination. This occurs on a routine basis, and the frequency of this exam is concordant with an individual's age, existing health conditions, and risk factors. The visual acuity assessment involves the Snellen chart, which can detect one's need for vision correction. Pupillary health can be tested with a pupillometer, transilluminator, or pen light. Intraocular pressure can be determined with the Goldmann tonometer. Rhonioscopy using eye drops to numb the eye and a slit lamp can determine one's risk for glaucoma. Extraocular motility and alignment using a light can evaluate eye movement. The slit lamp exam can allow the ophthalmologist to visualize the vasculature and general anatomy of the eye. During the exam, different eye drops can bring specific areas of interest into focus. This exam can help diagnose macular degeneration, detached retinas, cataracts, corneal injuries, and retinal vessel blockages. The funduscopic exam, with the help of an ophthalmoscope, can examine the back of the eye, called the fundus, and the retina, optic disc, and blood vessels. The refraction exam using a photoreopter enables the ophthalmologist to determine how to correct a patient's vision. The Ishihara color vision test can diagnose color blindness. Some limitations include the delayed timeliness with results from the exam, The individual's required attendance, agony or discomfort in dealing with the side effects of the eye-numbing drops, the cost of the test, although an ophthalmologist should only suggest certain parts of this exam as patients are required. Specialized tests are conducted by the ophthalmologist after the basic eye examination indicates any abnormality. Optical coherence tomography, which provides a cross-sectional view of retina, uses interferometry to detect and confirm specific abnormalities in the retina and optic nerve. A limitation of OCT involves inability to work effectively when encountering patients with vitreous hemorrhages, dense cataracts, and corneal opacities due to the use of light waves' inability to penetrate. Optical coherence tomography angiography allows for the visualization of the vasculature of the retina and choroid and is conducted to diagnose retinal arc conditions, glaucoma, and uveitis. As in OCT, a limitation of OCTA is the presence of certain types of artifacts which may impede its accuracy. Electroretinography, or ERG, and electrooculography, or EOG, are both utilized to determine retinal status. The ERG is the preferred test, although when Best's disease is concerned, EOG is the correct exam to perform. Visual field testing is performed at the perimeter and is used when individuals are at a high risk for vision loss. Corneal topography is computed using keratoscope and provides a map of the cornea. Ophthalmologic ultrasonography is used when issues that impede the OCT or OCTA tests are encountered. Traditional eye surgery involved using anesthesia of some type, either local or general, depending on the degree of difficulty in a sterile setting. Cataract surgery is one of the most common. Surgeries to correct glaucoma include the following: trabeculectomy, where an incision is made to allow fluid to drain, glaucoma implant, where a shunt is placed to allow for drainage, and minimally invasive glaucoma surgery, or MIGS, a collection of surgeries to reduce pressure. Surgeries to correct abnormalities in the cornea, eye muscle, lacrima, and sclera are also performed. Each of these current surgeries correlate with their own limitations depending on the patient, level of difficulty, and available tools. The traditional model involves an ophthalmologist working out of a physical location 4 days a week and once performing surgeries. For patients, they must first see their primary care physician, who then refers them to an ophthalmologist. Some limitations in this traditional, non-technology-based approach are avoidable referrals, prolonged wait times from start to finish in receiving results, and dealing with redundant medical professionals. Also important to note is the difference between an ophthalmologist, an optometrist, and an optician. An ophthalmologist has the most medical training, can prescribe many medications, perform all types of eye surgeries, and complete full eye examinations. Optometrists perform limited eye exams, minimal surgeries, and prescribe some medicines. Opticians mainly assist in helping patients with eyeglasses and contact lenses. I'd like to now discuss one of the most frequently performed eye procedures, manual cataract surgery, or MCS. Also known as phacoemulsification, MCS is performed when an individual is determined to have several cataracts on the eye. An incision is created in either the sclera or cornea, and a tool is used to then break up the cataracts. It is then removed, and an intraocular lens, or IOL, is implanted to replace the removed lens. Limitations include manual incision use, risk of complications like posterior capsular tear and vitreous loss, and the need for replacement of the IOL about every 15 years.
I am Cami Sue Grant, and I will be handling the third part of this presentation. I will be identifying how technology-based approaches increase access to treatment of eye diseases and disorders. The increase in technology in ophthalmology is directly related to several factors. Digital interventions, including the further strengthening of telehealth, the expansion of 5G wireless networks, artificial intelligence such as machine learning and deep learning, and the Internet of Things, as well as digital guidelines established by global organizations such as World Health Organization has led to substantial innovation in mobile technology and ophthalmology. For this section, I chose not to focus on one particular disease because I wanted to show the full potential of technology and ophthalmology because it surprised me and I know it will surprise you too. On this slide, I outlined the 4 T's and 1 M to applying technology to ophthalmology. Telehealth enables ophthalmologists to evaluate their patients remotely. This may seem like it may not be useful in ophthalmology, but stay tuned. Telehealth can assist doctors in becoming more efficient and may create a better allocation of inadequate health resources. Teleophthalmology is equipment that can be used outside the doctor's office and transported for public events. Telementoring is ophthalmologists giving assistance to students or other practitioners virtually to educate or assist in surgery. Telesurgery is a new technology in its early stages where surgery is performed by an eye surgeon from a remote site. Testing has only been done on rabbits so far. And finally, mobile applications, which can be used by patients and ophthalmologists, and is the focus of this presentation. This slide shows some of the data of the availability of smartphone applications for ophthalmology. Android and iOS dominate mobile sales, and this is reflected in the availability of ophthalmology applications. A large portion of the available apps are geared to visual acuity screening. 13% was designed for eye relaxation exercises, 12% for professional education. The remaining applications available are used for detecting color blindness and low vision aid assistance and patient education. This slide outlines the different types of smartphone applications that can be used by ophthalmologists and patients. I was pleasantly surprised about the number of applications available. This is just a partial list of available apps. iHandbook is the most popular application used by ophthalmologists. This app has a visual acuity test, eye atlas, and a ton of medical and academic resources. iTilt is an easy and cost-effective way to measure how many degrees a patient's head is tilted during an in-person eye exam. Be My Eyes assists blind and low vision patients with volunteers who can assist them with everyday tasks. Eye Drop Alarm reminds patients when to take their eye medication. Visual acuity charts can be used both by medical professionals and patients. This slide outlines traditional approaches versus technological approaches. Traditional approaches is where doctors could only diagnose and treat patients during an office visit only. Patients had no tools to assist them with previous diagnosed conditions. Doctors had to rely on expensive equipment for diagnosing and assisting with patient examination. Technological approaches. Virtual healthcare allows for evaluation of patients remotely through mobile technology and telemedicine. Mobile technology and digital education for both provider and patient. And virtual care visits through Zoom, Skype, and WebEx, which are HIPAA compliant. Mobile applications that can be used in the doctor's office and can lower the cost of obtaining expensive equipment. This slide outlines the benefits of technology in mobile applications in ophthalmology. Ophthalmologists can monitor stable patients and reduce unnecessary visits and tertiary care. Updated digital information is available for both provider and patient to be accessed through mobile applications. There are less unnecessary visits, which reduce healthcare costs and office waiting times. Mobile applications can go anywhere and everywhere. Access to care is expanded by overcoming barriers to access, such as location and time constraints. It allows clinicians and doctors to provide quality health care outside of clinics and improve the access to medical care and patient outcomes.
This is Josh with one of the limitations of the technology-based approaches and recommendations for further research. Telemedicine is one of the frontiers of technology-based approaches in ophthalmology. Its limitations include the need for IT infrastructure, internet connectivity, reimbursement, and cybersecurity measures. We also have to keep the user in mind and cater to them. And to address this, we must stress the importance of education, guidance during its rollout. More research must be completed to further understand the impact across the population. Thank you.
This slide lists the limitations of the technology-based approaches and recommendations for future research. The cost of telehealth ophthalmic equipment and supplementary personnel training is a possible limitation to new technology acceptance among doctors and patients. The diversity in individual insurance policies and governmental regulations are key challenges for clinical implementation of teleophthalmology. For future research, artificial intelligence, computer system development of tasks that are normally done by humans will extend and expand the use of digital ophthalmology. It has the potential to improve the accessibility, availability, and productivity of current resources and overall efficiency of eye care services.